exam is going to take place. We said what's this is August, so at the beginning of August, we need to figure that out. 5th, 12th, 19th, those any of those Saturdays, um, and it has to be in the Hialeah campus. So just remember that. Anyways, more about that whenever. Yes, a test should be on the 5th. I have not confirmed with testing. I've already emailed them, so they take a while. They should tell me, hopefully uh, by either tomorrow or the beginning of next week. I'll for sure confirm. Usually, what they're doing is Saturdays 10 o'clock in the morning. So we'll make sure that that's there. And if it's that day, then I will confirm. I will help you guys. Uh, uh, and that's something that we should probably do tomorrow. Let's see how to register for the NHA. Okay, so that's kind of the next big step. Anyone, for whatever reason, anyone can't do it that day, or so August 5th, August 12th, those are the 2 days that I gave for it.
So are we picking the 5th? Or I know I can't do the 12th, but the 5th, yes.
The 5th is the day that we have. So I submitted
Okay.
those 2 days with priority on the 5th.
Okay, great,
Means
great,
that
great.
we had to
Okay.
submit more than one day just in case. Uh, but I cannot say like the 12 is not. So it looks like it's gonna be that if they have the space, the time, the bunch of things that they have to do. But it looks like it's gonna be the 5th.
Okay, thank you.
Okay, so let's talk about that later, just in case. As soon as I
Teacher,
have the official date, I'll let you know.
teacher,
Uh,
then I can choose the day.
well, no. If
No.
we get the 5th, it's the 5th.
Okay, okay.
So that's kind of what we said before. So that's what I submitted. So it looks like it's gonna be that day. In case it's not, then I'll let you guys know what they say in regards of any other day. Kamika just said that 12 is not, so maybe you won't be able to change it to that day. So I'll just let you know whenever I have a more concrete. Now, what we need to do, and this is something that we could do tomorrow probably, is have you guys set up for the NHA. So I'll help you out with that, and then I'll show my screen how I do it, so all of you follow, and then we could change, make sure that everyone has it. That will take a while, so yeah, we could do that tomorrow. And as soon as you have it, then you'll be free to go. So, anyways, let's continue with this. Of the exam. Let's get ready for the exam, and then uh, and then set it up. So in this section, we're gonna talk about insurance. We're gonna talk about eligibility and other pay requirements. We already know this. Whenever you see a sign next to any of the signs next to the topic, it's gonna be the terminology, electronic records, professionalism, and reimbursement. We already know the mentors, Billy and Cody. Again, whenever you see Billy, you're gonna see something that has to do with the billing or the reimbursement part. And coding, again, it will give you more information on coding. There's a module that is for coding, and it's the next module. So you're gonna see him a lot more like that one. So one of the things that we need to cover in this section is when to verify patient's insurance. Uh, when you're verifying that, what is primary and what is secondary. We talked about it extensively last, and when we were doing that on the PowerPoints. And then what is coordination of benefits? Remember, coordination of benefits is the rule that says that someone is going to be primary and someone is going to be secondary. Okay, and none of them can pay more than combine 100%. So usually, when you see a patient that has two insurances, then again, one will pay a thing, the other will pay the other thing, and usually it's a percentage, and the percentage is always, not always, but most of the time, divided into 80-20, 70-30, 90-10, stuff like that. So that's the first thing that we're gonna do. Now, I want you to look at this. We showed you last time the first section of it: registration, scheduling, patient check-in, utilization management. So patient registration and scheduling is to put the patients into the system and schedule them for a visit. Patient check-in is when the patient actually gets to the doctor's office or to the place that they were gonna get the service. And utilization management is checking for medical necessity. After that, we are, and here's where we're gonna start now, in healthcare encounter documentation, uh, and uh, and anything that has to do with that. Okay. So, like always, remember all of this has to do with the life of the claim or the revenue cycle. Is how much we go from registration to how much steps we have from registration to payment. Now, what payment by who and how, and that's kind of what we're going to determine in this section. So, one of the things that you need to understand is that most of the things are going to be kind of the same for everything that you do. It's going to have rules and regulations. So, one of the first things that you need to go over is the patient's demographics. This is name, last name, sex. I like how this is says sex and gender, sex, gender, date of birth, mailing address, contact information, anything, and then the reason for the visit. Now, the important part is that this all this information is gonna be captured by whomever is in the front end. So, who is uh, the secretary or whomever talks to the patient. Now, in new patient registration, it's important that you know that we have a little bit more information to ask for because we don't have that information. We don't have all that information yet. But in the existing patient, we already have all those things. We just confirm that nothing has changed, including the insurance information that can change at any point. So you can have something like this. That is a patient demographic form, and this could be um, put in your software. So again, simple information, name, address, email, phone number, stuff like that. Now, in the reason for visit, this is gonna be per visit. So sometimes you're gonna have a date and then the reason for visit for that date. So one of the things that you need to understand is that that information has to match the information that the third party payer has or the insurance company because that's how they're going to identify the patient. So if the patient has a different name from what they have in the insurance, then there's no payment. So a policyholder, and this is the definition for policyholder, is the individual who signs the contract with the health insurance company. That might not be the patient. Okay, that might not be the patient. It could be a policyholder. It could be someone that's working, and then they have an insurance company or insurance plan for their spouse or for their kids. So policyholder and patient might not be the same. Guarantor will not always be the patient. That's exactly what we're saying here. Guarantor is the individual who is responsible for paying any patient responsibility after the insurance has processed the claim. So who is responsible for that? It could be the patient, but not necessarily always. So the same thing, guarantor or policyholder might be someone different from the patient. An example of other types of insurances, other than private and governmental, are gonna be workers' compensation, car insurance, homeowners insurance. This is a thing that I want you to pay attention to. I'm gonna be super exaggerated here. I'm gonna go different colors. I'm gonna go crazy here. This is something that is really extremely important. Okay, extremely important. It's gonna be on your exam. It's going to be in a question to confuse you. Okay, I don't know what's happening to my stars here, but there you go. Important. Okay, super extremely important. Anything else? I don't know. I don't know how else to make it seem that it's important. Electronic medical record and electronic health record. I'm pretty sure I already covered this, but I'm gonna do it again. Electronic medical record is the patient's medical record from one healthcare organization, from one provider. So if you go to your primary doctor, you have a medical record from that primary doctor. If you go to a cardiologist, you have another medical record from that cardiologist. If you go to a hospital because you broke your leg, then you have a medical record for that encounter when you broke your leg at the hospital. If you combine those three different medical records, we call that electronic health record because it includes and is shared and used by more than one organization or provider. So usually when the patient has an HMO, there's a medical record for each provider, and there's a health record that is where everyone can put the information or get the information because they're all under the same umbrella, under the same insurance company. So just think about that whenever you see that question. Medical record and electronic health records, for the most part, when we talk about them in class or in practice, it will be exact same thing. But in the exam for the past 10 years, they've asked a question to differentiate between medical record and health record. Okay? So hopefully we get it properly. Spotlight. There we go. We talk about workers' compensation. Workers' compensation is insurance that is provided for patients that are injured or get sick or need any type of medical care while because of something that happened while they were performing their duties when they are working, okay, or something that has to do with work. The employee will get medical treatment, rehab, and loss of wages. So they will pay for loss of wages. Um, in order to do it, you need to make sure that the patient uh, uh, identifies the problem as an injury related to work, and in that regard, they're gonna get a case number, date of the injury, and they're gonna have a case worker that will navigate that patient through the whole from getting sick to getting back to work. Now, it's gonna have a different medical record if that patient goes to the same doctor for a non-employee related or non-employment related injury or sickness. They'll have a different one just in case uh, to separate them and make sure that nothing is overlapping or we're double dipping in any ways. Hmm. The other example that we talk about is car insurance, auto insurance. Auto insurance will have kind of the same things as auto insurance. For example, premium is the amount that the patient has to pay for the uh, for the plan for the insurance plan in order to receive benefits. Okay, so if you want to receive benefits, if you want your car insurance to be up to date and pay if you get into a crash, you have to pay your premium. The same thing as you have to pay your premium uh, for your uh, health insurance in order for it to be active. Now, we talked about deductibles in the past. The deductible is an annual amount the patient has to pay before the insurance will begin to pay for cover benefits. Now, in car insurance, it's not an annual, excuse me, it's not an annual amount. It is a per accident amount. So if you get into a car accident, usually your car insurance will have a deductible of, it depends on which one, but around $500. Okay, so if the damages are $1,000, okay, you have to pay first those $500, and then the insurance your insurance company will pay the remainder $500. That is per accident. So deductible is per accident in car insurance. In health insurance is per year. So it's one annual fee that has to be paid or met before the insurance company starts paying for cover benefits. And I want you to understand that is not uh, something that has to do with the payment. It is something that you have has to do with the contract. So if one day you pay your deductible completely, then the next time the insurance will pay the cover services, or at least a percentage of the cover services, and then you pay whatever co-insurance you have. So all those things are not part of the payment; is part of the uh, the contract that you have with the provider, with the insurance company. Now, co-payment. What is co-payment? Co-payment is something that goes and accompanies the payment. So it's a flat fixed amount that patient pays for specific services in a case by case basis. So every time you go in, you pay. Every time you visit the doctor, you pay. Every time you visit the hospital, you pay. So it's something that additional to the payment. Because some insurances will have different lines of business, meaning that they will have different uh, contracts, then just because you have one specific insurance or your patients have a specific insurance, that doesn't mean that all of them are going to have the same premiums, the same deductibles, the same co-payments. 9 out of 10 times, they're completely different. So again, this is just me saying something extra here. We're talking about auto insurance, but it's talking about deductible, and the deductible in car insurance is uh, a little bit different. Okay, so deductible is per accident. Homeowners insurance, kind of the same thing. If someone is walking in front of your house and you have a crack in your in the front of your house, in the gutter, in the sidewalk or something, if someone falls, they could go against your um, homeowner's insurance. And then again, details of the accident, date of the injury, how it happened, and then you will have, like always, for all of these ones, claim number, and if anything, you will need to separate the information from the previous record if the patient had one. So if you break a leg because of someone's property, and you go to an orthopedic surgeon that you know that you've been there before, we have to create a new one, just like we did in the workers' compensation case. Now, this is a thing that this is more for real life. So whenever you end up going to work for a billing company or for a doctor's office or a hospital or a clinic, when do you verify insurance? When do you verify eligibility for that patient? Well, you do it every time you see the patient. As a good rule, you do it every time the patient is going to get a service. Now, you should do it at the beginning of the revenue cycle. That is when the patient registers. And I always joke like this: you call a doctor's office and you say, "I want to see the doctor," okay? And they'll ask you, "What insurance do you have?" Nothing else. Nothing else, nothing less, nothing more. What insurance do you have? If you have an insurance that the doctor takes, that means that they are participating providers of that insurance, then yes, you can make up an appointment and see a doctor. If your insurance is not in the list of the insurances that that doctor participates with, the next question will be, we do not take your plan, but do you are you willing to pay out of pocket? And then depends on what the patient says, then do you make an appointment or not. So it's really important that you know what insurances are we as a provider you are participating with. So that will be a list of all the insurances. In some insurances, like I said, they have different lines of service. For example, let's say you have a Medicaid, a Medicare, HMO, and you have a private. So maybe you only participate in one of those, either the HMO for Medicaid or for Medicare, or you don't participate for the HMOs. You only participate for the private ones. So all that information is really important for the one in the front to know. Number one. Number two, you need to know which ones will require co-payments, co-insurances, stuff like that. So that is more on the back end. That's more the biller's responsibility. So usually what they have is a list of all the insurances, and then next way will say, does it need pre-authorization? Does it need referral? Do they have co-payments? Kind of like that, and then you look, check, or you memorize that. But at the beginning, you're gonna be checking. Okay, this patient has Humana. Okay, Humana does not have a referral clause, so boom, let's see the patient. Or if not, then you say, hey, we need to figure out this referral before you actually are seen. Or then the insurance has a co-insurance, and the co-insurance has to be collected as after the services are done, after the remittent advice and the EOB gets there. So co-insurance is a predetermined percentage that the patient is responsible to pay for cover services once the annual deductible has been met. Remember, everything has to do with the deductible. Deductible is zero because you didn't have one or because it's paid. Then the insurance kicks in, and they will pay uh, after that is done and for covered services. Okay. So again, this is how the Medicare card does not look like. Does not look like this, but let's say this is an HMO for Medicare. Member's name, account number. The account number is a combination of the patient's social security number and a letter at the end, and then it will tell you which ones they have, Part A, Part B, and then the cover period. Remember, it's a yearly thing, and it's the same in every state. So you'll see them. Now you can go into the computer and search for more information. For example, deductible, and if the patient has any other parts of Medicare. Remember, Medicare has Part A, B, C, and D. Part A is for inpatient hospital claims. Part B is for outpatient or doctor's offices, stuff like does not require hospitalization. Part C is Medicare Advantage plan. The C used to be for choice, so Medicare Part C or Medicare choice plans. If you decide to take Medicare Advantage plan or a choice plan, it is an HMO or a PPO where you are going to give your benefits to insurance company, and they will manage those benefits. That's why it's called managed plan. It's choice, so it matches the letter C because it's a choice of the patient if they want to do it or not. They do not have to do it. One of the things that you need to know if the patient is the provider is in network. So when a provider is in network, it means that the patient has signed an agreement or a contract with the insurance plan to see their patients, and the insurance company has agreed in that contract to pay that provider for seeing those patients. Out of network is when the provider does not have a signed agreement with the insurance plan. So the insurance plan does not have to pay that patient, that provider for the patients they saw. So that's where the first question starts. What insurance do you have? Well, we have Humana. Okay, we are in network with Humana. We can see you. Oh, we are out of network, and there's no payment coming from them. If I see you, then would you pay out of pocket? No? Okay, see you next day. Or, uh, well, then you pay out of pocket, and that's it. What information you can get from the insurance card? Number one, the insurance company name. Number two, the type of plan and the name of the plan. So the insurance company name, Humana. The plan type, Humana HMO for Medicare, Humana Medicare, Humana TRICARE. Policyholder identification number. That is a number that the insurance company gives to the patient. Policyholder name and any dependents. Usually when we have dependents, they will have the same policy number, and it will be dash 001, 002, 003, depending on how many individuals they have. If it is a group, it will have the group number. Co-payment requirements are going to be there. Member provider contact information uh, and claim mailing address, usually in the back. And then utilization review contact information also in the back. So let's see. No, they only have the one in the front. So the card will look something like this. Sample insurance is the insurance here, the state and the region, a logo here. Name, again, they don't have to be like that, but most look like this. Member's name, member's ID, dependents, 1, 2, and 3. Group number, VIN number, benefit plan, effective date, and then the plan, in this case, is a PPO. It will tell you what type of plan it is. And that's something that you need to kind of look at the card all over the place until you get it. You could say Medicare, Medicaid, Medicare HMO, Medicaid HMO, PPO, commercial. It will say something identifying the type of plan. And this specific amounts that you see here are going to be the co-payment. For an office visit is $15. For a specialist copay is $50. For emergency room, $75. And then the deductible is $1,500. Now that is the total deductible. It's not telling you how much of that deductible is met already. So for that, you will go into the back of the card, and usually in the back of the card, you're gonna have information about the where to send the claims by mail, link or the address for the portal for that insurance, where you are going to verify things as a provider or as a patient. Also, phone numbers for customers and phone numbers for providers. And then if you have any question, you just pick a phone, call those places, or go online. Usually those portals, you have to log into them first. So you can have that in order to check if the patient has the insurance valid for that day or not. One of the things that we show you all the time is um, the payments in a remittance advice or an EOB. So network providers are going to pay based on the contract, based on the allowed amount for those contracts. So this is a remittance advice, an example of one. This one says Medicare. It is has a little umbrella here to kind of make you remember that this is a plan, healthcare providers plan, but is a Medicare HMO. And that's kind of something that you need to understand when you see that. It's a remittance advice or remittance notice or EOB. The way that we in the industry call it is EOB. Everyone knows them as EOBs. Correctly, they are not EOBs. EOBs is what the patients get. The providers will get a remittance advice or a remittance notice. And this is an example of it. This is the provider's number. This is a date. This is a check. So we're getting paid. Patient is Mr. Wallace here. This is the date of service. This is the place of service. Doctor's office, for example. 99213, you already know that that's an evaluation and management, level 3. We billed 157 for this one. This is what, Illinois. And then allowed was 87. There was no deductible, so the deductible was paid already. They had a co-insurance of a percentage, 1740, and then the provider will pay the rest, 6960. Yeah. So 6960 paid by the provider, 17 paid by the patient as a co-insurance, then that's where you go. Patient responsibility 1740, adjustments for the totals, they don't have them here, but previously paid, interest, late, net, this is the payment, 6960. Now you go to the patient's account and you say, well, we billed this, this is what was allowed, we got this from the patient, this from the insurance. Now I calculate whatever the difference between this whole payment, these two payments uh, minus from the bill amount. That will give me my adjustment, write off, boom, everything is a zero. Patient doesn't owe anything, nobody owes anything. We're good. So that is really important. Um, Way of understanding. This is how they look. You should be able to get that information from looking at that. They're all completely different. Some of them will have some of them will have in the bottom a legend. It will tell you why, if it was, for example, this one, why they're paying 87. So it will say something like contracted amount. It's 87, not 157, whatever, or allowed amount, and it will tell you why if they pay less or whatever you build. The other thing that we said is coordination of benefits. Coordination of benefits is uh, um, a way of determining who pays what, who pays first, who pays second, who pays the most, who pays the least, who pays 80%, who pays 20%, whatever it is. Now, the important part is that we cannot go over 100%. Okay, so we cannot go over 100%. If a plan pays 80, the other one can only pay 20. If one pays 50, the other one can pay 50. One cannot pay 50 and then the other one pay 80. That will be over 100%. So it's really important that you know that we cannot overpay. If you overpay, that could be considered abuse. So, simple way of understanding this. You are going to figure out who pays first, who pays second, what does the insurance supposed to pay, what does the patient supposed to pay, and um, and you do not pay more than 100%. Cover benefits, the services outlined in the policy that are payable by the health plan. Medical, major medical, surgical, dental, vision, whatever it's on the plan. Most plans are moving into having a primary care provider or PCP. It's a primary doctor that is going to be the gatekeeper before you go to specialty or before you go to diagnostic labs or any major procedure. That's going to be a lot to pay for. So again, I like this one as an example. I think you've seen it I guess in the book. So in this case, she has not paid her deductible. So she had a bill of $1,200 because she has not paid her deductible, and her deductible in this case was well, there you go. Plan deductible is $1,200. So she pays the whole thing. Okay, she's gonna pay the whole thing until she reaches the $1,200, and the plan will pay nothing. So for the office visit, then that was $100. She will pay $100 or anything until she reaches that. Then let's say she's gone to the hospital, to the office a couple of times, and she already paid that $1,200. It's already paid in the past, in the beginning of the year. So now uh, the plan pays an 80-20 co-insurance. So the plan pays 80 and the lady pays 20%. Okay? So for an office visit that before she paid in full, now she only pays that 20% and the plan pays the rest. Now, after a couple of visits or whatever it is, almost at the end of the year, she's reached the out-of-pocket limit. So now the plan will pay 100%. Sometimes that happens. Plans will have an out-of-pocket limit of how much the patient can pay, and it has to do with you know multiple visits, usually big surgery, stuff like that. Then the plan will pay 100% after that limit. Again, that's only if it has it. So for the same visit that the first time she paid $100, for the second time she paid $20. That third or last time at the end of the year she pays nothing. So this is kind of how it works. It's kind of weird to think about it because the office visit is exactly the same. How do I know that the visit is exactly the same? Because it's being charged exactly the same. So that doesn't mean that she's paying less or she's paying more or the insurance. It depends on where she is with her deductible and out of pocket limits or out of pocket maximum. If your plan, like in her plan, says in the contract says there's a deductible of $1,200, a co-insurance of 20, an out-of-pocket limit of 2,000, then that's the case. But if the plan had no deductible and no out-of-pocket, then the plan will pay this 80-20 split since day one all the way to the end of the year. If the deductible was higher, then she will have to meet that at a higher point, and it will be kind of the same thing. So just kind of understand that as it works. When we talk about co-payments, usually there are small amounts, less than $100 for doctor's offices and specialists and stuff like that. A little bit over that for ER services, um, ER visits, and then hospitalizations also and surgeries just go like really, really high. For co-insurances, we're talking about percentages, so that's split 80-20, 70-30, whatever it is. And then for deductible, think about at the end of the year, you have to pay that amount, or not at the end of the year, you have to pay that amount once a year. So you have to so you pay until you get to it, and after that, and the insurance company takes over and pays whatever percentage they have agreed on to pay. Many of the plans are gonna be doing what is called HMO, so Health Maintenance Organizations. It's a group of contracted providers that agree to the payment contract for its members. So a health maintenance organization is a group of people, a group of entities that are gonna be under an umbrella, and they will gonna get they're gonna pay at a discounted rate for service and procedures by giving the providers an administrative help, meaning that you don't have to go and chase for patients. I will send you the patients. But because I will send you the patients and you don't have to do that, then I'm gonna pay you less than if you actually went to look for the patients. So everyone that is under the health maintenance organization or the umbrella will benefit from the plan doing a lot of the work and then or the administrative work, and then the providers will have more time to do the providing of the services. Some plans are gonna make free PCP visits, for example. So if you're gonna go to the primary care physician, it could be completely free. The way that works is by them paying a capitation fee or paying the doctors for seeing those patients, regardless of how many times they see or how many patients they see. They just send them a specific amount. So with that, I can tell the patient, "Oh, this is free," even though it's not because it's being paid for. But I rather have a healthy patient that goes to the doctor's office a couple of times a year and they keep healthy than someone that does not go because they probably don't have the money and then they get sick and then worse things happen. So that's kind of how it works. Everyone gets a piece of the pie, and it gets kind of spread out, makes some things cheaper, makes some things harder still it's about the quality of the care and the price of it that we're trying to control here. And the insurance companies do a really good job of that, and they do also a really good job of keeping some of the money as revenue after the whole year of sending patients to different doctors. Our friend Cody is here with a little nugget of information. Is pre-authorization is not approved. The specialist can file an appeal and provide additional patient history to support medical necessity. So this is an appeal of denial for pre-authorization. So we're not saying that we did the procedure, we sent the claim and it got denied. We're saying that we called the insurance company and we said, hey, do you approve this procedure? And the insurance company says, no. So if they say no, you can appeal their decision, but everything has to be before you do the procedure. So pre-authorization has to be there. If you do the procedure without pre-authorization, even though that it was medically necessary, and you can prove it, the rules are that you need a pre-authorization to do it. So if you don't tell the insurance that you need to do it, if you tell them and they say no and you still do it, then you don't get paid. If you don't tell them and you do it, you won't get paid. If you tell them and they say yes, then you will get paid. And one of the things that I want you to understand is that who's responsible for getting that information? Who's responsible for getting the pre-authorization? Who's responsible for getting a referral? Well, if it's a requirement for payment for a service and you are going to receive that payment, then you are responsible. You, the medical builder and coder, are responsible for getting that information, or um, you won't get paid. Simple as that. Some things are not going to get paid regardless, and those are going to be what we call non-covered services. They are services that are not payable by the health plan. We already know that. Medicare has a bunch of them. Remember that when it's a Medicare patient, there's an advance beneficiary notice of non-payment that you have to sign before you do the procedure, and you tell the patient, hey, Medicare is not going to pay for this, you will be responsible for it. And then you give the patient a chance of deciding if they want to uh, do it or not. Because if they don't want to do it because they don't have the money to pay for it, then they don't have to do it. You cannot force a patient to do something and then tell them, well, now that it's done, you have to pay for it. That's not how it works. So that's why that advanced beneficiary of non-covered services is there for the patient to actually decide if they want to do it or not. There's a bunch of things that you could do for estimate how much the patient is supposed to pay. So you have this in all of your software. So again, you put information on the patient, the account, the policy, the group, um, and then you put what the the insurance is. In this case, sample insurance, place of service, office, and then you go through the things. There's no deductible. There's no family deductible, out of pocket maximum. But you tell them, hey, these are gonna be the charges, more or less, based on the things that are gonna be done. This is the allowed amount. This is what the insurance will pay, and then this is a reminder that you have to pay when the deductible is met. So because your deductible is met, then you have to pay $350. If the deductible was not met and you still owe like $1,000 for deductible, then it will say here $1,000, and then you will have to you will owe $1,000 plus 350. And then you tell the patient before, like, if it's something gonna get paid or not, based on your what the information that you got, how much will they have to pay, or how much their financial responsibility is going to be beyond the co-payment, beyond the deductible. What the percentage is, for example. So, uh, 25, 25, 75. Yes, this is a 25. So this is a insurance payment 75, patient 25. Okay, so this is a 70% 25. It should say here anywhere. It should say here. So this is probably for it is almost $2,000, so it's probably it's probably like a procedure or something. So for the family or professional visit, 0%. General benefits, 20. This is not 20. 75, 700, 700, 700. This is 25. So yeah, I'm not sure if that's 20. It should say 25 there, but again, you can calculate more or less and tell the patient, hey, this is more or less how you what you have to pay. For example, some places before they do the surgery, they will charge the co-insurance first, and then that will be the deposit that the patient has to put down before they do the surgery or the procedure. Um, there's many ways that you can calculate things. There's a few calculations here that that you could do. This is how they explain it. I will explain it this way also, but I know for a fact that you already know how to do it because I show you how to do it at the beginning of kind of the middle of the class. And we're gonna try this again, but this is an example. Someone has $5,000 surgery. They have 1,500 deductible. They only paid $1,000 for this year. Once the deductible is met, the insurance has an 80/20 policy. How much does the patient pay for the procedure? So the first thing that you do, again, here says you subtract the $500 from the total allowed charges in this case, because it's not saying not allowed. So this is allowed amount. It's not giving you charges. And then it tells you that it's $4,500 allowed amount minus deductible, and then you multiply it by 80% for the patient, and then you multiply it by 20% for the patient. Now, because the patient paid deductible, then you have to go. Patient responsibility is the deductible plus that 20%. So it's not giving you the whole thing. So but now just think about it this: the patient has a reminder deductible amount of $500, and the 20% uh, of the thing is 900. Now the total financial responsibility is low. So this is one way to do it, um, but it's kind of all over the place. I like my formula better because you put it and you just get all the information. You put the formula down and then you plug in the numbers wherever they go. So in this case, because we're not giving you charges, that we can say that that is the allowed amount. So it should say not cost of the procedure here. It should say allowed amount for that procedure. So again, kind of the same thing. I hopefully you'll be able to practice it again and get them right. You do not have insurance, then you're self-paid. Simple as it could be. We look for the charges and we charge you that to the individual. Now, many places will have what is called a cash price allowable for patients that do not have. So the way this works is, so let's say, and give you an example here. I don't think I ever gave you an example on that one. Let's see if I can write it. I'll use this corner. I'm gonna do it in this little box. Draw a box. So I'm gonna do it here real quick. So what happens if a patient does not have insurance and we wanna help the patient? So we can help the patient by saying, hey, listen, if we charge $100, the allowed amount, for example, is 75, and the insurance pays, I don't know, 50% of that. Let's make it $30, for example, around 30, 250. Yeah. So the insurance usually pays 30 to 50 for that. Okay, and I'm okay with that. So whenever a patient comes in for that same procedure and they say that they are cash pay, then we'll say, okay, 3250. That happens. It happens a lot. Okay, we do not charge the patient the charges. We do not charge the patient the allowed amount. We charge the patient that is self-pay the amount that we will get from the insurance. That is what a honest doctor or practice should do. Okay, some of them will go like, oh, they'll charge you $100. It becomes something stupid because you're not charging $100 to the insurance company. I mean, you're not getting $100 from the insurance company. Why would you charge $100 to the patient that actually does not have the money to pay for insurance? So it's kind of weird. Some patients will say, I do not want to use my insurance because, for example, let's say it's 30 to 50 for the procedure, and they have a $50 copayment. Then they would rather not do it with the insurance, uh, or they have a co-insurance or whatever it is. So you have to navigate those two things properly. So usually a patient that is have an insurance, you're gonna use the insurance. If they say don't send it to the insurance company, that's kind of weird, but it could happen if you're seeing that they're trying to do kind of something weird, then you can always report it to the insurance company and say, hey, this individual came here and does not want to give us the insurance or whatever, like even though he has and whatever. So you could check your option, but usually that's what happens. Places are gonna say, okay, if we can get this from the insurance company, that is the same amount that I'm gonna charge the patient. So it seems fair, and it's not everyone does that. Now, insurances are gonna have specific allowed amounts and specific payments based on a bunch of things. So the Office of the Inspector General, again, it's involved in this, and they have what is called a good faith determination of financial need depending on the individuals. And the factors are cost of living, patient's income, patient family size, scope of extended patient's medical bills. So again, we have our friend Belly here. She says that determining the patient responsibility can be an area of weakness in the revenue cycle, because if you just go with what the provider, the insurance is gonna pay the provider on behalf of the patient, then there's some money that will not get there. Another thing is that just because someone has an insurance doesn't mean that they met their deductible. And if you don't check if the deductible is met, then you're sending the claim, and the claim will come back and say no payment because you were supposed to get the insurance, the payment from the patient because of the deductible, and then that money can be lost, and the patient cannot just not come back ever, and then you just lost that money. So you need to verify the insurance. You need to verify eligibility for that insurance every time you see the patient. Every time you see the patient, and before you do any procedure. You know the patient. This is Kamika. She always comes here. We always see her here. She came last week. She came last month. In between last month or last week, she changed insurances. She changed jobs. She got a better job. Now she has a better insurance. Okay, and you send it to the previous one, to the one that she had 10 years ago when she came to our office for the first time. That's not valid anymore. You get a denial. Kamika moves to, I don't know, to Los Angeles because she hit the $1 billion on the lotto. We don't see her ever. That is a thing that happens. People that owe money to a doctor's office will disappear from the doctor's office, will not go to the doctor's office just because they owe some money. They will miss appointments. They will just change doctors. Okay? And sometimes, and a lot of times, all of the time, you can always mediate that. You can always say, hey, you can make little payments. You can figure it out without stressing the patient more, or without uh, losing that money. So you have to be careful. You have to check all the time, every time, eligibility, and verify that insurance. Some people are gonna be working at doctor's offices and and clinics only verifying insurance. They're gonna be the ones that you send them. Here's the patient, here's the insurance, and they will tell you yes, it's good to go, or not, it's not good to. So just for that, it's so important because imagine you do all the thing and the patient does not have active, valid insurance, and that happens all the time. So someone stopped paying for the insurance or just didn't pay for it, or got laid off from their job, and now the insurance is not being paid, and they cancel the insurance, whatever it is. It's Medicaid, and they didn't do the recertification, so they lost their Medicaid benefits, whatever it is. And if you do not check that, then every time, then you are going to be performing services that are not going to get paid. And if you do not get paid, Billy doesn't get paid, the doctor doesn't get paid, nobody gets paid because there's no money. So super important that you verify insurance at the time of the visit, every time for every patient, because 75 to 80% of the money that comes to a doctor's office, to a clinic, to a hospital comes from insurance companies. 75 to 80% of the money that comes from the payment for procedures come from insurance companies. Less than a quarter of it is self-pay. So and the rest is just what you lose. So you have to make sure that you know that. Now, can you pay cash, check, or credit card? Of course. And many others will have different other ways to pay. And again, it's the way it works is doesn't really matter how it gets paid. It needs to get paid. For you guys, there's some other ways that you can have payments, but most of it comes from insurance companies. Here is the advanced beneficiary notice of non-coverage ABN. This is a document from Medicare or Medicare providers, in this case, healthcare providers, Medicare HMO probably. And it says, name of the patient, ID number, and the first thing says, if Medicare does not pay for the items detailed below, you may have to pay. Medicare does not pay for everything, even some care that you or your healthcare provider have good reason to think you need. We expect Medicare not to pay for these items, and then you put here the code or the treatment, usually both, the code, the CPT code, and the explanation of the code, and then why they will not pay for it, and then the estimated cost for it. And then, do you want the treatment? Yes or no? And you check this boxes if you want it. You check if you don't want it, and then sign and date. If this document, if this document is signed, it's really important. If this document is signed, you can bill the patient. If this document is not signed, you cannot charge the patient. So if you think that something is not going to get paid, have your patient sign the document. If the document is not signed, you cannot charge the patient. I don't care. You can appeal, you can cry, you can whatever it is. It's illegal to charge the patient for something that you did that did not go paid, and you kind of knew in advance that was not going to get paid. Usually they will say not payment, patient responsibility, depending on completion, on a previous completion of the advanced beneficiary notice. So yeah, if you don't have it, then no, you have to send it to them as dated, everything. If the patient sign it, yes, you can charge the patient. If not, no payment. So why? Well, because some things are considered to be either non-covered or non-medically necessary for the patient, and that's a way of controlling the cost, controlling like not every doctor will go crazy and start doing things just to charge Medicare. that will be abused. So and or some things are just non-covered because they're not. Um, some modifiers that you're gonna have uh, for codes after CPT codes, modifiers that will say they have the advanced beneficiary notice or not. Do you have it? If it's signed and perfect, good, you have one. If you don't have it, there's another one. If you didn't, because you thought it was not needed, it's there. And if it's exempt or denied, again, also there. So these are examples of modifiers. Every time you see a modifier, what you have to do is get the modifier and go to the description of the book and read it. So it will tell you what it is. So in the exam, you see one of those. What you have to do is go and read the description. Get it from the book and read the description. Types of insurances. We have a specific types of insurances that we talked about. We talk about government-sponsored insurance or government-sponsored programs. We call them insurance. They are not insurances. Medicare, Medicaid, TRICARE, TRICARE, workers' compensation. And then we have what we call the commercial or the private plans. The inside commercial or private plans, we have PPOs, point of service, HMOs, and those are plans that are going to take over the benefits from Medicaid, Medicare, TRICARE, whatever it is, and they will handle that those benefits how they see fit. They could have commercial plans being private or group. So a private is one individual or a family, or you could have a group, usually an extended family or an employer. And again, they all have premiums. They will all have co-payments, deductibles. Um, Usually, they work through series of networks. So if they have networks, they will have a PCP, primary care physician, that will send the patient as a referral to a specialist. Sometimes the referral is something that is needed in order for payment to happen. HMOs will have a specific way of working, so they work through the capitation method. It's an agreement with the provider to receive a pre-established payment for healthcare services to enrollees over a period of time, usually in a monthly basis. So we send the doctor this amount of money for this month, and they have to see all of our patients. If they see two patients, or if they see 200 patients, they get paid the same. So it's now the responsibility of the insurance company to send those patients to that provider, so the provider can just focus on seeing the patients. The other thing that could happen is that those HMOs will have uh, um, co-payments, and the more the patients go to that office, the more co-payment they get. So kind of balances those two things out. So the more patients I send you, the more co-payment. If I don't send you a lot of patients, then you just got the money and not that much of co-payment. So kind of balances it out. Capitation, like I said, is typically per month. HMOs plans are gonna be like that. Usually PCP visits are free and everything else is paid. We do have kind of the same thing with Medicare, Medicaid, and TRICARE, that they could be HMOs. So just know that again, they are not insurance plans; they are programs or plans, but not insurance plans for different types of the population. Medicare is for individuals that are 65 years or older, that have Social Security benefits because they've worked in the U.S. And paid for Medicare. They could be patients that have end-stage renal disease at whatever age. They will be uh, they could get Medicare, or they could be disabled before 18 years old. So kids that are born with a specific congenital deformity or disability, they could end up getting Medicare as kids. Medicaid is for individuals that are low income. In order to do low income, we need to figure out by state. And then TRICARE is for active military personnel and their families. Medicare is paid by the federal government. Medicaid is paid jointly between the federal government and the state government, and TRICARE is paid by the federal government, the Department of Defense. TRICARE is for tri means the three different branches of the military: Army, Air Force, and Navy. Medicaid is for helping individuals with low income, and Medicare is for taking care of our elderly. We have three different plans for Medicare. So A, B, and D. If you have C, that just means that you have a Medicare Advantage plan or choice plan. Medicare Part A is for inpatient hospitals. Part B is for provider professional service in outpatient settings. And Part D is for prescription medication. C is an option, it's a choice C for a managed care plan. At that point, you're taking all of those things and giving it to uh, an insurance company, a private insurance company that is going to manage that care plan. It's a choice. That's why it's Part C, choice, or managed care plan, or an HMO. Uh, Medicare premiums are based on income, just in case you ever ask about it. They do have a projected premium. They do have deductibles, and how much they make, and stuff like that. So it's not everyone will get it. So uh, Medicaid, kind of the same principle. So Medicaid, different is that it's only is jointly paid by the federal and the state government, and is managed by the states. So there's money coming from the federal government and from the state, but it's managed by the state. So each state can just decide what they're gonna do and where they're gonna put the things. Um, you could have Medicaid and Medicare. So Medicare for elderly, Medicaid for low income. If you are a individual that is 65 years old or older with Social Security benefits and Medicare benefits, and low income, you could end up having Medicaid also. And at that point, we call them Medi-Medi. So when you have Medicare, Medicaid, you have Medi-Medi. Medicare pays 80%, Medicaid pays 20%. Medicare will be primary, Medicaid will be secondary. Medicaid will be secondary or the plan of last resource. Always, if you have anything and Medicaid will be second or last. If you have any private plan and a government sponsored plan, the private plan will go first. The government sponsored plan will always be second. We talk about TRICARE as being the active military personnel for active military personnel and their families. Retirees and surviving spouses also can qualify. It's for the three branches of the military. You have to be active military. If you are not active, if you are disabled, for example, the next thing or the next I think we saw it. Okay. The thing that's not what it's on. The thing that you will get is CHAMP VA for the Veterans Affairs Administration. So CHAMP VA for disabled military personnel. Again, you have to be disabled while active duty, and then you get CHAMP VA. We talked about coordination of benefits before, but now we're going to do it properly. The coordination of benefits, the provision of healthcare plan define the order or responsibility for the claim whenever we have more than one payer. So who's first, who's second. and we need to make sure that we don't have overpayment. So the maximum that we could pay is 100% of the allowed amount. Example here, sample insurance, healthcare providers, remittance advice or remittance notice, Mackenzie J, 327, date of service, and then we have other dates of service here. Um, where, doctor's office, what happened, what was billed, what was allowed, any deductible, any core insurance, and then payment. Adjustment, kind of the same thing. In this case, says claim information forwarded to Tricare for life. So again, this is not showing you um, this is not showing you coordinator benefits. This is showing you just a random advice with different dates of service here. Different dates of service, and then different things, different payments. And again, really important, patient responsibility. If you add patient responsibility and the payment from the provider, that should be exactly the allowed amount. If you go billed or charge minus the allowed amount, that will be the write-off or the adjustment. Simple example here, whenever you have employer primary insurance, and then you have something as a secondary, usually it's an 80-20 coverage. So 80% will be with the primary, 20% with the secondary, exactly like Medicare and Medicaid. You could have a third insurance. It's super rare. It's not super rare, but it's rare. Usually is when a kid is under mom or dad's insurance, um, or for example, someone has a specific condition, or we have anything else. It could happen, but again, if it happens, then that 80-20 is going to change to something else, but it cannot be over 100%. That's part of the provisions of the coordination of benefits. Usually, another thing, when you have claims like this, you send it to the first payer first. They send it back with whatever they are supposed to pay, and whatever is the rest, you send it with that remittance advice to the secondary insurance so they could pay the rest. So again, remittance advice or EOBs is the receipt. It's the thing that comes with a check saying we charge this, we pay this, and you charge this, we pay this. This is how much is left, either for another insurance or as the patient has to pay. We talked about this a few times, birthday rule. It's 100% going to be in your exam, 100% for the last 10 years I've seen it in the exam. It's a patient, a kid that has mom and dad, usually mom and dad have a job and they have each one has an insurance, and the kid is under mom and dad's insurance. And then when the kid goes to the hospital or goes to the doctors, we need to decide which one is primary, which one is secondary. So the birthday rule says that if there's any confusion, uh, the this is the description. For a child or dependent whose parents or guardians are married or living together, the caretaker who has their birthday earliest in the calendar year, month and day, will be primary. So, mom was born in January, dad was born in December, then mom is primary, dad is secondary, regardless of their age, regardless of who was born first in a year. The year does not matter. It's the month and the day. If both caretakers have the same birthday, the caretaker who had the plan the longest is primary, and then the birthday rule kind of is irrelevant. A court order has the authority to specify primary plan of a child or dependent when both caretakers have health insurance. So it could be a court order, or the birthday rule applies if the court order specifies both caretakers are responsible for health insurance or there is a joint custody and both caretakers have insurance plan that cover the condition. So if both parents have their kid under their insurance, regardless if they're married or not, regardless of anything, the birthday rule says that whomever has the earliest birthday in the year using month, day, and month, then that's going to be primary, and the other one will be secondary. Timely filing. Timely filing is the time that you have in order to send a claim to the insurance company. Usually, to keep it super, super simple, it's between 30 days and 12 months. For private insurance companies, is 30 days up to 45 days. Some insurances uh, have a 45-day rule for timely filing. Most of the insurances have a 30-day timely filing rule. Medicare, Medicaid, Tricare, and other insurances that are government sponsored have a 12-month, 1 calendar year for you to submit the claim. Blue Cross and Blue Shield has a 12-month uh, window also. So most of the insurance companies have 30 days, some have 45, those are private insurances. Everybody else, government sponsored, and Blue Cross and Blue Shield have a 12-month. Now, if a patient has Medicare through an HMO, let's say Humana, then it goes to the 30 or 45 days. So just because the claim is Medicare, we're not going to send it to Medicare. We're going to send it to Humana because the patient has Humana Medicare. Then now you have uh, those examples. So private insurance, HMO, PPO, whatever it is, 30 to 45 days. Free Medicaid, free Medicare, 12 months. So here, commercial insurance plans typically offer less than 1 year, except Blue Cross Blue Shield, that has some other timely filing for 100. This is specific Tennessee, for example. But again, it's for most of the plans, it's going to be 30 days. There's a few to make it more attractive to providers, then they have 45 days. Most of the time, you're gonna do it. You're gonna send it maybe like a week after the service is done. For example, you do the many places. What they do is that they start doing the claims and batch the claims, and they send them once a week. Just to have time to create them and file them properly. If you have many of them on queue, you can do it before, but around a week is the time that you're gonna send them. So if you send them on Fridays, for example, the claims from Monday will be 5 days old, and maybe on Friday you don't send the Friday ones, so the Thursday ones have the 1 day old. So you can send the claims as soon as the same day or the next day, or usually in a span of a week, and then you get paid around 14 days after. So if you send a claim Friday that you did on Monday, then 14 more days, so you get payment of that claim that was done Monday 21 days after. So you have to be, batching them and sending them really, really fast to have a good flow of uh, cash to the office. Anything that goes wrong, anything that you need to figure out, you're gonna do it through CMS. CMS is a Centers for Medicare and Medicaid Services. It's a federal entity that will check, provide all of the information. They're going to use Medicare Administrative Contractors, also federal entities that are going to be the ones that check for the claims, and they're going to pay them. So again, Medicare is not an insurance plan, so it's done a little bit different. So if this were private insurance, send it to the private insurance, and they're gonna be a claim adjuster, and they're gonna pay it or not pay it. Here we have independent contractors that are gonna do exactly that that same thing. Yeah, we're at the end already. A few things to remember. Um, the we talk about co-insurance, co-payment, premiums, insurances, co-insurance, percentage, co-payment, flat fee that you pay per visit, deductible, uh, dollar amount that you pay per year. All of those things are going to be responsibility for the patient. Co-insurance, percentage for the patient, co-payment for the patient, and deductible or premium also for the patient. The provider is going to get paid based on the contract that they have with the insurance company, and then the insurance company will pay a percentage of the allowed amount. Advance beneficiary notice. We talk about the document that is the advance beneficiary notice, where it states that something will not get paid, and you have to tell the patient in advance. If you have it and it's signed, you get paid. You can charge the patient, and the patient can pay you. If not, it's illegal to ask that patient for that money. Um, we talk about the revenue cycle. How do we use the administrative data and what errors can delay reimbursement? We did that last time. And what we're just talking about now, cash flow um, depends on how fast you send the things and how you do it in a consistent basis. You need to understand the financial responsibility to be able to explain it to the patient and just to understand the revenue cycle. At the end of every visit, you should check for the patient responsibility. It's either co-payment, deductible, or co-insurance. That if you do not check, that's money that's not you're not gonna see it, and those are losses on your part. We talk about the type of payers that require specific things. We talk about Medicare, Medicaid, TRICARE that have a specific timely filing time, different from insurance companies. We talk about workers' compensation and any other type of like liability or homeowners insurance that they will have a case manager. If those patients go to with a workers' compensation case or a liability case, and they go to a doctor that they've been there before, they have to have a separate account and separate medical record. We talk about the medical record and the health record, how the medical record is different from the health record. Medical record is your medical record inside one provider, and your health record is multiple providers. The medical records of multiple providers on one patient, and they can all look, edit, and use. Last thing that we talked about was coordination of benefits, untimely filing. Coordination of benefits is the way that we make sure that we don't pay more than 100% by the form of a patient having more than one insurance. We could have one, two, three insurances. We need to figure out which one is primary, which one is secondary. We said that private insurances are always primary to government sponsored plans. But if you have two private insurances, then and both of them are primary, and it's a kid, then we use the birthday rule to figure out who is primary, who's secondary. If you have two government-sponsored plans like Medicare and Medicaid, then Medicare always primary, and Medicaid always secondary. Any questions, my people? I know this is again kind of the same thing, me talking a lot and you guys saying nothing, but um, this is a say that again. I'm sorry.
We're just following, the information.
Yeah. So I have all of this for you guys for the for the 4 modules. It's just not uploading because it's huge apparently. All of this information I have the modules, and I have maybe I'll separate module 1, 2, 3, and 4. That will be um, 4 files, and then I'll separate all the terms in one Excel file. So that will be 5 files. maybe I'll have to break it down even more, but so you will get this. I think tonight I'll figure it out, and then send it to you guys. If not, then by tomorrow morning you should have it. I think that one of the things that we are missing is to set up your NHA account. I'll try to do that with you guys tomorrow. So as you guys come in, I know some of you get here a little bit later, but I'll just start with the ones that are there, and we'll make sure that all of you have your NHA accounts done properly. If you have it already, we will review and check that it's correct. Um, and then that we cannot register for the exam yet, uh, but we will be able to select the date, or at least put the at least put the date on for the exam. So that's kind of the next thing. And we have one, two, three, like four more classes. The last three for sure are gonna be practicing everything. So we'll figure out what's next. Any questions? Anything before I let you guys go? Anything? Okay. So if there's no more questions, I'll see you guys tomorrow. Remember, tomorrow